today we're going to take Tessa's blood pressure. So first of all, before we even put the cuff on, we want to make sure that there's no restrictive clothing around her arm area, which there isn't. We also want to ask for consent, so is it okay if I take your blood pressure today? Yes, great. So firstly we're going to put the blood pressure cuff nice and high, like I just mentioned. We want to make sure that the arrow that states artery lines up with her brachial artery there. Okay. So now it's nice and snug around Jess's arm. We're going to grab our stethoscope. Make sure that the stopper of her arm is nice and relaxed and that the stopper valve is done up properly. Okay, so now we're going to place the stethoscope over her brachial artery just here and listen until we can't hear her heartbeat anymore, and do one pump of the stopper valve above that. Right, so after listening to that, we have a systolic pressure of 110 and a diastolic pressure of 70, and that falls within the normal range. We want a systolic pressure to show something below 140 for someone who was normal blood pressure, and for systolic we want it to be below 90. If someone was hypertensive, their blood pressure for a systolic value would be over 140, and for diastolic it would be over 90. So today we're going to start off with some vital signs. In particular we're going to begin with Zach's radial pulse. So when we're looking at the systolic pressure, it should be around 80 millimeters of mercury, and a normal heart rate can range from 60 to 100 beats per minute. We also want to look to see if his pulse is bounding, if it's strong and regular, and if it was weak it would indicate some maybe abnormal cardiac dysfunction. So next I'm going to ask if it's alright if I can take your radial pulse. So now we're going to time for 15 seconds. So after timing for 15 seconds, I counted 18 beats that occurred, so we're going to times that by 4. And so that's 72 beats in a minute, which falls within the regular range of 60 to 100. It was also nice and strong and bounding, and it was very regular, so no indications of any abnormalities there. The first part we're going to be looking at is Zach's respiratory rate. So we're going to look at his breathing for 15 seconds, watching the rise and fall. So we want to ask if we can do that first. Is Zach, is it alright if I take the respiratory rate? Okay, perfect. So ideally, we actually wouldn't want to tell the patient that we're doing so, just in case they change their breathing pattern, or take 2 less or 2 more breaths. Alright, I'm just going to watch your breathing now. So we've watched Zach's breathing for 15 seconds, and in that space of time he's with 4 breaths. So we want to times that by 4 to give us 16 breaths in a minute, which lies within the normal range of 12 to 20 breaths in a minute. The second part of the respiratory assessment is the auscultation of the lungs. So we want to listen to the chest at the apex and the base, posteriorly and anteriorly. We're listening for any abnormal sounds such as wheezing, crackles, wails, or stridor. So I've just explained what we're going to do, but I'm just going to ask if it's alright, Zach, if I can put my stethoscope underneath the top to listen to your lungs. Okay. Consent is very important because this procedure is quite invasive, so we just want to double check that everything is okay. Right, so I'm just going to put my stethoscope down the top. So if I can get you to breathe in and out. Just coming on the other side. I'm just going to do it underneath the top here at the front. So breathe in and out. Just the other side as well. I'm just going to look at the back of your lungs as well. Just putting my hand on.
Yep.
Yeah, okay. Breathe in and out for me, please. And again. I'm just going to go right down the bottom here, right? One more time. Right, so while we were listening to Zach's lungs, we were doing it for about 2 to 5 seconds, just so if we can hear anything. There was nothing abnormal that I could hear indicating that there was normal lung function. While I was listening, I was watching his chest and abdomen rise and fall. He wasn't struggling to breathe and his volume and depth looked good. There was no shortness of breath, it wasn't too deep, and he wasn't sitting in a tripod position. We're going to do some airway management. This is known as a oropharyngeal airway, also an OPA. So firstly, to insert, we're going to make sure we tilt the patient's head to open the airway, and then we're going to measure the OPA from the mouth to the mandible to ensure that it fits. Next, we're going to insert facing upwards halfway, and then we're going to twist and turn and push, avoiding the tongue. That is your insertion of an OPA. So complications of the OPA can include vomiting due to the OPA being too large, damage to the oral pharynx, also if the OPA was too large, and a worsening ear obstruction if the tongue is pushed posteriorly from the OPA. We would use an OPA if the GCS was less than 8 and also if the verbal score was lower than 2. Another form of airway management is known as the nasopharyngeal airway, also known as an NPA. So before inserting, we want to measure this device from the nostril to the mandible to ensure it fits our patient. Following that, we want to lubricate it with a water-based lubricant, like so, for an easier insertion. When we come to insert it, we want to be at a 90-degree angle to the person's face and we want to push. If there's any resistance, we want to twist 180 degrees and continue to push. If there was more further resistance, we can change nostrils, and you want to make sure that the flange reaches right down to the nostril, like so. So the benefits of using an NPA is that it doesn't cause vomiting or a gag reflex. You can use it for a patient with a GCS score higher than 8, and you can also use it for patients that have locked jaws or clenched teeth. You wouldn't use an NPA for a patient that had a base or skull fracture, and the complications can include nasal polyps or bleeding. So when using the suction device, we want to make sure our patient is in the recovery position. So if he vomits or anything, it comes straight out instead of going back and swallowing. Before actually putting the rigid catheter in to clear any obstructions, we want to test the device. So we want to turn it on, and we want to occlude the airway, making sure it goes past 350 millimeters of mercury. It does. We also want to test for suction, making sure it works. So when we insert the catheter, we only want to insert it as far as we can see, and we want to move it in a circular motion and only sucking on the way out, like so. So we only want to do suction for no more than 10 seconds so the patient can breathe. And we also do not want to use a rigid catheter while in a moving vehicle. We have soft catheters in the back of these suction container tanks. So the complications of the suction can be induced vomiting, bradycardia, hypoxia, aspirations, laryngospasms, and soft tissue trauma. So today for fracture management, we have a patient here with a suspected tibia fracture. So the first thing I want to do before doing anything is explain every procedure that we do, gaining consent beforehand as well. If the patient is right to give consent. We want to expose both the legs so we can compare the injured one to the uninjured one. We also want to try and gain a history to find out what's happened to this patient, how they've actually hurt their leg. So when we're assessing the legs, we're looking for loss of function. We want to ask them to wiggle their toes to see if they can do that. We're looking for any unnatural movements, swelling, irregularity, any shortening of the legs, any deformities or crepitus on palpation. We also want to be aware that our patient, due to this fracture, could be going into shock, so we just want to keep an eye on that as well. Next thing we want to do is look at the neurological and cardiovascular integrity. So for this we want to feel the temperature above each leg, like so, making sure they're both the same. We want to check the sensation, so we would rub the bottom of the patient's foot here and ask if they can feel anything. We want to look at the capillary refill, comparing on both feet to check that it's under 4 seconds by pinching the toe. And we also now want to ask the patient what kind of pain they're in. So on a pain scale from 0 to 10, we would ask them to give us a rating, and this can help us determine what kind of pain relief we can give to them before we do any kind of splinting and demobilisation. So our patient here has said that his pain is 7 out of 10, so I've decided to administer methoxyfluorine. It is used for moderate to mild pain, and it has a rapid onset of 2 to 5 minutes. And it's also a self-administered pain relief, so the patient here can control how much he or she wants. Before we give this drug, we want to ask about contraindications, so whether this patient has had any renal impairment, family history of malignant hypothermia, whether they had actually had methoxyfluorine within the last week, and if they're unable to obey commands, we would not give this pain relief. So my patient here is alert and has answered no to all of the contraindications, so I am okay to give this. I'd also let my patient know about the side effects, so something such as euphoria, drowsiness, lightheadedness, and nausea. I'd also say that it was, that's quite normal, and reassure the patient that if they feel anything like that, just let me know, but it is quite normal. We've also checked the 5 rights before giving this drug, so we look at, make sure it's the right one, it's the right dose, right patient, route and time. We'd also want to check it with our colleague to make sure that they agree. So now I would give this to my patient and I would ask them to take 5 deep breaths. You can't use a dummy. And if we're in an ambulance, we probably use a mask, just due to the fumes that can be created by this pain relief. To immobilise the fracture, we're going to do this by splinting, so we want to choose an appropriate splint, and in this case we're going to be using a box splint. So before we use it, we want to explain the procedure and gain consent from our patient. We also want to reassess the pain scale, so our patient has had methoxyfluorine, and we've asked him what his pain score is now, and he's rated it 3 out of 10, which is definitely an improvement. We're using this to immobilise and protect the injury before transport, and we're also going to be using a towel to provide a bit more support and comfort. We're going to bandage the box splint below and above the injury site, and to do this I have my colleague to help. So, just get easy look at the leg. Now we're just tying above and below the injury site to secure the split. Now that the split is secure on the injured leg, we want to reassess neurological and cardiovascular integrity. We're checking the temperature on both feet, comparing, making sure they're warm. We also want to check for sensation, so just rubbing the back of the foot, seeing if our patient can still feel it, and just comparing cap refill, making sure it's still less than 4 seconds to ensure blood flow. We also want to ask again about pain scale, rating it out of 10 to ensure that they're still not in that much pain and it's manageable for transport. So now we're going to do a familiarisation with the Life Pack 12. The first thing you want to do is check the batteries. So we'll turn it around like so, undo the buckle here, and at the back there are 2 batteries. To check the charge, we want to press the grey button on each of them to see the level, and they're both fully charged. If they weren't, you could remove like so, take it out and replace it with a fully charged battery and put the old one back on charge. And back in like that. So now we want to turn the Life Pack 12 on. So to do that, we press the green button and we're going to set it into manual mode. We do this by pressing Analyze then Energy Select. And turn the dial to yes. It's okay. And we want to set it to 50 joules to run our user test. Twist the dial to 50 joules, we press OK. And we want to choose and select the user test. So to do so, press Options, scroll down, across, press the dial to run the user test, and it's in progress. So as you can see, the piece of paper here says user test passed, so we know that the machine is good to go. Next thing we want to do is test the defib. So to do this, it's on the left hand side. Get the wire out and attach it to the test modem, like so. Now press charge. Charging to 50 joules, so everyone stand clear. And now I'm going to press shock. So the shock is being administered, so we know that it works. We also want to check that we can disarm the shock, so to do so, same thing, we press charge. Everyone stand clear and press dial, and it says disarming, it stops the shock from happening. Okay, so when we're dealing with wounds, wound management, that kind of thing, we want to remember to wear our personal protective equipment, so gloves, glasses. We're dealing with blood, so it's a bodily fluid, and we want to be aware that there could be transmissions of diseases or something along the lines of that. So the first thing we want to do is expose the wound, make sure it's free of any clothing, anything like that. We also can clean it with a saline solution just to get rid of any debris or things that could be inside the wound. Also, if it was a more open wound, we could pack it with some moist dressings just to help control the bleeding. This one's not, so we don't need to do that. If it was a smaller wound, we could also use an adhesive dressing on top instead of doing the full wrap around like I'm going to demonstrate. So first of all, what we want to do is get the bandage and fold it up as small as possible. We want to do this so we're applying maximum amount of pressure. So we're going to place it like this. So if you could just hold that there. And then we want to come around and wrap it in a figure 8 kind of pattern, and then also twisting it to help apply stronger pressure than that. Right, so I'll get you to put that there. So we're coming around in figure 8. After dressing the wound, like we have here, if it was continuing to bleed through the bandage, we could apply another one. We could also elevate the arm like so, helping reduce the blood flow to the extremity. Another thing we could do is grab another bandage and we could place it indirectly under the armpit here and having the patient close it tightly, providing an indirect kind of pressure. The thing we want to be sure of with these kind of wounds is making sure that we haven't cut off all the blood supply to the area, so we would want to check the distal pulse here. Yep, and it's nice and strong. We would also want to check capillary refill, just making sure that there's sufficient blood flow, which there is. So in regard to a catastrophic hemorrhage, we want to apply a tourniquet at least 10 centimetres proximal to the wound, so up here. I'll demonstrate this now. So we'll slide this up. Twist the windlass right up until there was no distal pulse or the bleeding had actually stopped. This little tab here, this little white tab is where you would write the time that you applied the tourniquet. This is to inform any other staff, hospital or AMBO when it was applied, and just so they're for their own information. If one tourniquet doesn't stop the bleeding, we could apply another one just to try and control it a bit more. If the wound was not on an extremity, such as an arm or a leg, but for example with a sucking chest wound, we could use defib pads to cover it, or if it was in the abdomen region, we could use cling fill wrap. So I'm going to be showing you the application of how to put on a cervical collar, also known as a C collar. Before doing so, we want to be using the Nexus rule. So Nexus stands for National Emergency X-ray Utilisation Study. And we also want to think about the indications of why we would be applying this collar. So if they have posterior midline tenderness on their C-spine up here on palpation, making sure that they're not intoxicated, that they have a mental status with a verbal score of 5 out of 5, neurological deficits, so numbness in their fingers and toes, and also no distracting other injuries. So before we apply the C-collar to our patient here, we want to explain the procedure and then gain consent. So first of all, what we want to do is I'm going to ask my colleague here to stabilise the head. Thank you. Next we want to come in and measure from the base of the chin to the clavicle with the fingers like so. So that's about 4 fingers. We want to come and measure this against the collar to make sure for a proper fit. So 4 fingers, push it right down, like so. Now we want to bend it just to make sure it's a bit easier to put on, a bit more comfortable. I'm going to come in here like this. Under the chin. Just working around. We want to pull it nice and tight. Now we'll stabilise the head and we're ready for transport. Today when we're demonstrating oxygen delivery, we're going to be using a high concentration mask. This would be used for a patient, for example, who had rails. So firstly, we want to check our regulator and the Botox seal inside. We want to check that it's in good condition and not damaged or worn down. If it was, you'd want to replace it. So next we're going to attach the regulator to our oxygen. So we're going to slide it on as so. Then we're going to twist it right up. Nice and tight, and we want to do a quarter turn back. And so now after this we want to test how much oxygen is actually in our bottle. So we want to turn it on, and this would give us a PSI reading on the gauge shown here. This one shows 1600 PSI. Next we want to test the flow rate, so we would turn the dial. This is measured in litres per minute, so you can go right up to 25 if need be, but you just want to turn it on and hear that there's oxygen coming out. Now that we've tested that the oxygen tank and the regulator all works, we're going to attach the tubing to the bottle. So we're going to put this part of the tube right here. With a high concentration mask, it runs 90% oxygen. So for this patient, we were going to run it at 10 litres per minute. So we turn the dial as so. Next we want to lie the bottle back down to ensure as a safety precaution. Now normally the bag would inflate, but unfortunately we don't have any actual oxygen, so we're just going to imagine that it does. So we would now place this on the patient, obviously telling and warning him that it's happening. Put it around like this. Ensure that it fits. You can then also tighten the mask with the green straps on the side to ensure a comfy, secure fit. Delivery is complete. The next thing we want to do is flush the regulator. So first things we would do is we'd take the mask off the patient, like so. Then we would turn the oxygen off. So turn down the flow rate and then turn this one here. Okay. Now we would remove the tubing from the oxygen bottle and turn the flow rate back on, which would release any excess oxygen, like so. When using a BVM, also known as a bag valve mask, we want to test for any leakage or damage that's occurring. So we want to cover this here, press and see if there's any, if you hear anything, notice any damage. We also want to test the reservoir bag, so attach it like so, and fill the bag up, checking to see if you can see or hear any damages. So now that that's been all checked and we're good to go, we're going to attach it and assemble the BVM like so. We're going to put it running on 10 to 15 litres of oxygen as the flow rate. And normally when we would attach it to oxygen, the bag would fill, but unfortunately we don't have any oxygen, so we're just going to pretend that it's actually happening. Next we want to perform some airway management on our patient. So we want to tilt the head, opening up the airway. I'm going to be using an OPA on this patient. So we're going to measure it from the mouth to the mandible like so. And as you can can see, this one fits perfectly, ironically. Now we're going to insert it halfway, and we're going to twist, avoiding the tongue and pushing right down like so. So when placing the mask over our patient, we're going to want to go from head end first, over the nose, over the mouth. We want to put our hands in a CE grip and pulling the chin backwards. When we ventilate, we want to ventilate every 5 to 8 seconds like so. In doing this, we want to watch the chest rise and fall. We also want to be assessing for any gastric inflation. So normally there would be a second person here assisting me, and they would be putting a downwards pressure with their fingers on the cricoid cartilage, like so, towards the spine. This blocks off the esophagus, which stops aspiration and gastric inflation. It's also important when using the BVM to remember the acronym MOANS to assess the effectiveness of this device. Hello, ambulance. Right, so we're coming in and we're going to assess the dangers. We want to look for anything, if we can smell it or if we can hear anything. Next thing we want to do is assess the response. So, hello sir, can you hear me? Just tapping on the clavicle to see if there's any movement. Next thing we want to do is check the airway for any obstructions, so tilting the head back, just having a look, there's nothing. Now we want to listen for breathing. I'm also watching the chest and doing it at the same time for 10 seconds. Okay, so he's unresponsive if you could start CPR. We also note that he's a pale blue colour. So now what I'm going to do is I'm going to set up the AED. I'll just work around you.
Analyzing confidence. Do not touch the patient. Shock advised. Charging. Stay clear of patient.
So everyone just stand clear, so just move back a little bit.
Deliver shock now. Raise shock delivered.
Okay. So if you can continue with CPR.
Stop CPR.
Now what we're going to do is some airway management to help this man breathe. We'll be using the bag valve mask, so it's important to refer to the acronym MOANS. We'll be running this device at 15 litres of oxygen for a minute. I'll insert an OPA, like so. I'll just call for backup now as well. So AUT to comms. We have an R49 requesting an R50. Also during this period of time, it's important to ask any observers what's happened to this man. So if you could let me know when you get to 30 conditions, please. 25, 26, 27, 28, 29, 30. Chest rise, chest rise. It's important to watch how far my partner here is pushing the chest down. We want it to go a third of the way. No strong rhythmic compressions. We're also wanting to watch the chest rise, making sure that it is fully inflating. 26, 27, 28, 29, 30. Chest rise, chest rise. Just rise, just rise.
Stop CPR.
Right.
Analyzing confidence. Stay clear of patient. Analyzing confidence. No shock advised. Pause. If needed, start CPR.